Hello, everybody. My name is Daniel Strbian from Helsinki University Hospital, and I'm here in the role of Fellow of the European Stroke Organization. And we are very happy to have today Professor Chris Bladin, and we are going to discuss the results of the TEXAIS trial. So welcome, Chris. And first of all, I can just congratulate you for completing of the trial despite the difficulties that we've been seeing in the last years or months. And I can just tell that as far as I remember, this topic was quite a dilemma. So congratulations for finishing of the trial. Maybe just the first question for you, Chris, would be that hypothesis, the primary hypothesis was chosen to be change in NIH stroke scale points and not maybe what we are generally used to modify ranking scale. So maybe do you have any explanation for this?
Yeah, it's a very good question, Daniel. So we thought about this a lot, and we decided that because this was a phase 2 study, we were looking to see if there was a biological signal that the treatment of hyperglycemia or the prevention of hyperglycemia using Exenatide could directly impact the improvement of the ischemic penumbra. So this was very much a study focused on the biology of the ischemic penumbra as opposed to focused on clinical outcomes. We're looking for a biological signal. We knew that Exenatide was quick acting. This form of Exenatide we were using was quick acting. And we knew that multiple studies, animal studies, human studies, had shown that hyperglycemia impairs the improvement of the ischemic penumbra. So I was really looking at an early biological signal that keeping glucose under good control would result in a better or a reduction in neurological disability. The outcome of greater than 8 points in NIHS was based on what's known as MNI, or major neurological improvement, and it's a commonly used criteria in many studies, because we know that even if you do nothing in acute stroke, patients are going to improve, and improvement is usually around at least 4 or 5 points, possibly a bit more if they've had thrombolysis or thrombectomy. And so we needed that clear biological indicator. So that's why the 8-point improvement was selected. So it was around an early biological signal to see if keeping glucose under control could impact upon the ischemic penumbra. Okay,
thanks, Chris. Well, this is reasonable. Thank you. Now, my second question would be about the admission glucose. So basically, if I remember correctly, it was median like 6.6, but the 95th percentile was 8.2 and 8.5. Did you expect such values, or maybe you have been expecting a bit of different numbers?
Yeah, so that was quite interesting, and it really fell into line with a lot of other studies. They talk about 50% plus of patients who come in have hyperglycemia on admission. If you look at the diabetic population, it's even higher. And in Texas, we found that 42% of patients had hyperglycemia on admission. So it fell very much in line with a number of other studies that have also looked at this. Okay, good.
And now, based on what you have presented to us, so it seems that the drug was quite well tolerated. And as you mentioned, of course, as expected, there was some nausea, vomiting cases in the active group, about below 4%, and no hypoglycemia episodes, no symptomatic hyperglycemia. Were there any other safety issues in the trial?
No, it was very well tolerated indeed. In fact, I was quite surprised how easy it was. It's just a very simple subcutaneous injection, and of course, it's very very well done by the pharma companies these days, where they have an injector pen that you just inject it. Because of course this is supposed to be used by diabetic patients out in the community. So for the medical staff treating acute stroke patients, giving Exenatide was very simple. What we did was we were proactive to prevent nausea and vomiting. So at the same time, patients were commenced on antiemetic therapy for the first few days, just to make sure that no complications would occur. We know from all the diabetes studies that the use of GLP-1 agonists and particularly Exenatide, there is a small proportion of patients who do get some nausea and sometimes vomiting. So we wanted to be proactive about that because we don't want vomiting occurring in our stroke patients, of course. But as you've highlighted, it was only a small percentage of patients. It was relatively well controlled. So it really didn't cause any particular problems and didn't result in any major adverse events in the study.
Thank you, Chris. Now, you mentioned that the proper protocol dose was not reached in 30 out of 177 patients in the active arm. So do you have an explanation? Was it because of the technical issues, patient cooperation issues, and most importantly, are we going to see the per protocol analysis in sometimes later?
Yeah, that's a good question. So we had to look at this analysis carefully, and because as you've probably heard from the presentation, that the median NIHSS of patients coming to the study were 4. So they were, overall, they were mild strokes. There was no question about that. As a consequence, many patients came in very briefly and then were discharged. And so we took a rationale of saying, look, patients need to have at least 75% of the dosage before they could be considered to be adequately dosed. So a lot of the elements you've just described were related to the fact that some patients were only in very, very briefly and to receive their Exenatide. Sometimes it related to the fact that a patient came in very late in the day, in the evening, and there was a delay in getting their Exenatide for those various reasons. So there were all sorts of just simple practical logistic issues that resulted in some patients not getting an absolute complete dose of Exenatide. And this is one of the things you learn in these studies, and that really helps to inform how you approach developing a phase 3 study. So that aspect was really, really helpful.
Thank you. And you mentioned something that I was going to ask about in my next question, and it's about the admission or baseline NIH stroke scale. So basically it was median 4 in both groups, and of course this is challenging because those patients would have a good outcome anyway. And then if you think about the primary hypothesis, the change of 8 points, so it's really challenging to show any statistical significance.
Yeah.
Do you think it was like because of some other competing trials, most probably with large vessel occlusion, or how would you?
Yeah, exactly right. I think we had a number of trials looking at large vessel occlusions, and some of those patients were siphoned off. I mean, we know that LVOs account for about, maybe, and mechanical thrombectomy accounts for about 10% of our stroke patients, ischemic stroke patients. So a lot of those patients did go off into other trials. And look, this has been seen in a number of other studies where if you look at the broad population of ischemic stroke patients, then the overall NIHS is generally is quite low. So that was an issue that we would look to address in the next upcoming phase 3 study. And you may look to have 2 groups. You may have a broader group of all ischemic strokes, but you may then have a target group of LVOs, because exactly as you say, you'll have a much better chance of seeing an 8-point improvement in patients who come in with NIHSS over 10. Although we did have achievement of NIHS 0-1, that was the other alternative option. But as you say, if a patient comes in with a very mild stroke, they invariably do well. And to be honest, I was surprised to see that, in fact, as I've indicated, there was a little bit of a trend, although not significant, but there was a trend towards improvement in the Exenatide group. So look, it's all very encouraging.
Thanks, Chris. And the medical history was quite well balanced, as we could expect. Do you have any pre-specified secondary analysis of the patient with diabetes versus patients without diabetes?
Yeah, it's a good question. We looked at that. because the overall population of 350 was a small number, the number of diabetes patients is very small. So trying to draw any meaningful conclusions out of that group has been difficult. What is going to be interesting, though, is that as part of the study, we had patients wear a continuous glucose monitor. And so we've got a lot of detailed glucose data that's coming through, and we'll be doing some detailed analysis of that to see if that is going to give us some more finer points on glucose control compared to just the finger prick blood glucose levels.
Thanks, Chris. Now I'm coming to my final question. So now you mentioned it yourself that basically this is maybe we have good data for planning of the next trial. So if there would be something that is sort of learned from this trial, so what would you change maybe in regarding to baseline NIH, baseline glucose, or maybe not allowing only clinical diagnosis of the infarction? Have you been thinking yourself how to change maybe the design of the next trial?
Yeah, so obviously greater patient numbers. We initially targeted 528 patients, but we had to trim it back to 350 because of COVID and time constraints, etc. Certainly, we would be looking at a trial with probably many thousands of patients. Looking at issues like stratification of patients. So you have an LVO group, maybe, and in addition to maybe a broader group. So you can start to see if more targeted interventions with glucose control may be beneficial in certain subpopulations. The other thing that we could possibly do is also look at using a higher dose of Exenatide. We stuck with 5 micrograms subcutaneous. That was the lowest dose because I was concerned about the potential for nausea and vomiting, but it's possible that we could have another group, in fact, that got a higher dose to see if the side effect profile of that was adequate, because at a higher dose you would anticipate obviously stronger glucose control. So there's lots of different elements to this, I think, that really opens it up to that phase 3 study. But one of the key take-home messages I think that's important in this is that it's easy to use, it's safe to use, and it really is a very viable alternative to insulin therapy, which is difficult to use with no better outcomes. So I think use of these diabetes drugs to control glucose in acute stroke is got enormous potential. And for example, I see the day when patients will come in with acute stroke, and as they're coming into the emergency department, they'll simply get their shot of Exenatide, because we know it's so safe to use. It doesn't cause hypoglycemia. From the moment that patient arrives, their glucose control is underway.
Thanks a lot, Chris. So I thank you very much for your time, for being us here today and for discussing the TEXAIS trial, and good luck with the planning of the next phase. Thank you.
Thank you very much.